My favorite story about Bert, who was a good friend of Dr. Riordan's, was, I guess I understand this correctly, that you were like either a resident or a fellow or something, and some people got into some bad mushrooms, and it knocked out their livers, and they were kind of in coronary care in a holding pattern until they could find someone for a liver transplant. And so Dr. Berkson really screwed things up by giving them alpha lipoic acid, and darn it, they regenerated their liver function, and boy, was the transplant surgeon mad about that. Oh my gosh, he cured them. What nerve? So anyway, I'd like for now to go ahead and introduce you to Dr. Bert Berkson, talking about alpha lipoic acid in the care of certain cancers. Thank you, Bert.
Thank you for inviting me. It's a pleasure. I better say something about myself first. I never wanted to be a medical doctor, but somehow I started medical school in Chicago right out of college. I was sort of forced into it. It's a long story. And I'd ask questions all of the time, and the professors would always tell me to shut up. And then one day, one of the professors took me aside and said, you're very young, you're just starting out. We give you information, you memorize it, you give it back to us just the way we give it to you, and then you're a doctor. We don't want to hear any new ideas, we don't want to hear anything better. This is the way we do things, we follow algorithms, this is a profession, it's a guild, this is the way we are. And I thought, I don't want to be here anyway. I hated waking up early in the morning. At that time, you had to wear a tie every day, and I didn't like that. And I just didn't fit in. So I quit and went to the University of Illinois, got a master's degree, a PhD in area of microbiology, cell biology, and just loved the attitude at the university, graduate training. Became a professor at Rutgers University. I was actually a tenured professor by the time I was 33 years old. And then the family started having problems with doctors in Chicago. And I thought, maybe I'll pick up an MD as a sideline. I had 2 years of medical school and never practiced, just go back to my professorship. And I was on a committee with the dean of one of the big Ivy League medical schools. And I went to see him, and I said, I have the first 2 years of medical school, and I have about 7 years of education above that, but I don't have the hospital years. Can I do this at your institution? He says, Bert, if you ever became a doctor, you'd drive everybody crazy. And they drive you crazy, too. He says, you're a scientist, you're not a doctor, you think too much, we follow algorithms. He told me the same thing they told me at the university in Chicago. So, I don't know. He said, I think I could get you into medical school if you do the first 2 years over again. I said, I have all A's in my first 2 years. He says, you have not been programmed to think like an MD. Well, I didn't want this, and I had heard that the United States had given a piece of land to Mexico called the Chamazal. And one of the conditions was they build a world-class international medical school there. They had plenty of MDs, but they didn't have enough PhDs teaching the basic sciences. So 26 of us went down there, and we taught the basic sciences, and they allowed us to do the hospital years when we were down there. It was lots of fun. We had people from University of Michigan, from University of Tennessee, from Harvard, from Yale, from Stanford. We probably had the best teaching staff in the world. We were there 1 year, and a group came down from Case Western Reserve and Yale hospitals and said, what are you guys doing in Mexico for? Come up to New Haven or Cleveland, and we'll pay you for what you're doing. You can finish up here. So I didn't want to go. How many people are Yale grads? Well, I didn't like Yale when I was went there for an interview for graduate school years before. And I didn't know anything about Cleveland, so I went to Cleveland, finished up there, went into their internal medicine program at the university. And I was there a very short time when the chief of medicine told me, he says, "I'm really upset with you. You don't have any deaths on your service." It's a true story. He said, "Everybody's seen 15 deaths, and you haven't seen one. There's something wrong with you." I said, "Well, I try to keep people alive, you know that." He said, "We have 2 people who will surely die. They ate poisonous mushrooms. They have acute hepatic necrosis. They will be dead in 2 weeks." I said, "How do you know they're going to be dead in 2 weeks?" He said, "Well, our expert said so. You don't trust experts?" And I said, "No." He said, "Oh, you're a terrible internal medicine doctor. You are horrible." So he said, "They're your responsibility. They will be dead in 2 weeks. Go upstairs, watch them die, take notes, and present it to grand medical rounds in 2 weeks when they die." So I went upstairs and looked at these 2 people. One was going into a coma already. They were the sickest people I ever saw. And as a medical doctor, I should have followed the orders of the chief. But, you know, I'm one of those people that drive everybody crazy. So I called Washington, D.C., spoke to the head of our National Institutes of Health, Dr. Fred Barter. Barter syndrome, you might remember. And I asked him, "Is there anything in the world that'll regrow a liver?" This is 1977. And he said, "You know, we're studying alpha-lipoic acid as the wonder drug for the reversal of diabetic neuropathies and other diabetic problems. But when we give it to people with diabetes, they seem to regrow their organs." So he sent me 2 cases. I ran down to the airport, picked it up, injected it into the 2 people. Within 2 weeks, they regenerated their livers. Dr. Barter was so impressed, he came out to Cleveland with a team of doctors, set up a national conference on organ regeneration, asked me to be the lead speakers. The chiefs wanted to kill me. They said, do you realize we told these families they would be dead in 2 weeks, and now they're alive and well? You made us look like a bunch of fools. Are you more loyal to your patients or your fellow doctors? I said, "My patients." He said, "Boy, you'll never make it in internal medicine." And I knew I wouldn't. I couldn't wait till I got back to my professorship. Well, today I'm going to talk about alpha-lipoic acid effects on the mitochondrion and human disease modification. Lipoic acid is a 8-carbon octanoic acid molecule, very simple. On one end, 2 sulfurs, on the other end, a carboxyl group, sometimes called alpha-lipoic acid, thioctic acid. Lipoic acid has many actions. Probably the most important action is the rate-limiting factor for the production of energy from your food. And I'll talk about that in a little while. It modifies gene expression. It's a free radical scavenger. It recycles all of the other antioxidants. It's a glutathione regenerator, stimulates organ regeneration. It's a heavy metal chelator, restores T cell function, enhances insulin sensitivity, and many more things. In parts of Russia, when somebody has a myocardial infarction or a CVA, right in the emergency room, they give them alpha-lipoic acid, and it reverses ischemic reperfusion injury almost immediately. We produce tremendous amounts of lipoic acid as children. As we grow older and older, we produce less and less. And here we see glycolysis that we're all familiar with. Occurs in the cytoplasm. Glucose is converted to pyruvate. Cancer cells typically go beyond this and convert the pyruvate to lactate, even in the presence of oxygen. Do we have a pointer? I forgot my pointer. It's okay.
Someone, you know where that went? I was up here.
I don't see it. Oh, thank you. Okay, here we go. Okay, here we see pyruvate being produced by glycolysis, and this is the acetyl-CoA that goes into the Krebs cycle. Lipoic acid is a very important part of pyruvate dehydrogenase, and you'll see why. And without this, you don't get any energy. Without this, you'd be dead. Alpha-lipoic acid is fundamental for the conversion of food to energy. ALA is the rate-limiting factor for the production of energy from food. And here we see the pyruvate dehydrogenase complex. It's actually 3 complexes, 3 metabolic cycles. And over here you can see lipoic acid, lipoic acid. In other words, this doesn't work without lipoic acid. And this is why we're all alive. This is so important. It's essential for a eukaryotic life, for aerobic life. So lipoic acid pushes anaerobic metabolism into aerobic metabolism. ALA accelerates this process, and it's more than just a cofactor. Alpha-lipoic acid inhibits pyruvate dehydrogenase kinase. This is the enzyme that converts alpha-lipoic acid inhibits pyruvate dehydrogenase kinase. It inhibits the enzyme that converts pyruvate into acetyl-CoA. So it inhibits pyruvate dehydrogenase. Alpha-lipoic acid stops this enzyme. Pyruvate dehydrogenase kinase inhibits pyruvate dehydrogenase, so there's more available pyruvate dehydrogenase, and that results in increased pyruvate being directed into the Krebs cycle over the conversion of pyruvate to lactate. That sort of speaks for itself. Since a young person produces enormous amounts of lipoic acid, what happens when you feed a Thanksgiving meal to a 2-year-old child? He's going to be running around the house afterwards. 80-year-old man hardly produces any lipoic acid. Feed him a Thanksgiving meal, he'll be sleeping on a couch, then. Unless you give him lipoic acid, and I've done this, and he'll be walking around the house. What if a mitochondrion receives too much lipoic? Doctors Vigil and Couch back in the 90s did an LD50 study. They asked me to be part of this, but I didn't want anything to do with killing monkeys. In fact, I like some monkeys better than I like some people, or many people. So they did an LD50 study in 1997. Following these studies, I was urged to observe the necropsies and help with the electron microscopy work at the university. During the necropsies, I observed extensive necrotic lesions in the liver, kidneys, heart, large muscles of the extremities. These monkeys probably died terrible deaths. Here's a healthy primate mitochondrion. You see the double membrane structure, the well-defined cristae. These are ribosomes. So mitochondria from animals who received extensively high doses of lipoic became extremely edematous and demonstrated a complete disruption of the crucial membranes. These mitochondria did not exhibit the regular double membrane structure, but showed a coalescence of these structures with a deliquescence of membranes. This is the way the mitochondria looked after about 90 milligrams per kilogram. They fell apart. Vigil, Dr. Garcia, and myself published this earlier this year. Liver mitochondria suffered severe structural damage by extremely high doses of intravenous alpha-lipoic acid. So in reality, much lower doses may cause serious bouts of hypoglycemia. So the doctor and nurses, if you're giving this, must at all times watch the patients carefully. In some people, even very low doses of Lipoic will cause them to go into hypoglycemia. With appropriate Lipoic levels, the mitochondrion functions normally. If the mitochondrion does not contain sufficient Lipoic, it suffers and the organism dies. If the mitochondrion is supplied with excessive amounts, it accelerates aerobic respiration and the process runs ahead of itself. The mitochondrion heats up, free radicals accumulate, and the membranous components break down. It is interesting to note that therapeutic doses of Lipoic help the liver regenerate, but extremely high doses cause liver necrosis. And of course, you know, unreasonable and excessive amounts of anything will cause big problems. Does ALA help regenerate livers? The first large-scale clinical trial of intravenous alpha-lipoic acid was done by Dr. Barter and myself and colleagues at National Institutes of Health from 1977 to 1980. We took 79 people who were considered liver transplants candidates. Most of them had acute hepatic necrosis. The majority had eaten poisonous mushrooms, which is probably the worst thing you could do to the liver. And 75 out of 77 regenerated their livers within a month. I wrote a short note to the New England Journal of Medicine, and when it was published, hepatologists from all over the place would call me up and write me notes saying, "How dare you treat liver disease? You're not a hepatologist." And I'd say, "Do you want to know what I did? Well, we have nothing to learn from you. You're a microbiologist. Stay out of our business." Well, Barter and I were invited to Germany to be visiting scientists at the Max Planck Institute. This was 1978. I always wondered how such a wonderful person as Dr. Barter, such a kind, decent, wonderful guy, could rise to such a high position in our government. It was amazing. He was a terrific man. And we reported in 3 publications that we treated 79 people and 75 regenerated their livers with just intravenous Lipoic acid. I was appointed the Food and Drug Administration chief investigator in 1983, and that lasted for 23 years, and no drug companies had any interest. One of our papers was thioctic acid in the treatment of poisoning with alpha-amanitin. The paper should have read, ALA reverses acute hepatic necrosis, because you know, that didn't mean much to many people. Most of our people, as I said, ate poisonous Amanita mushrooms. One bite could kill a man. And these are the kind of results that we saw. Here's a woman, ate a poisonous mushroom. She tasted delicious. She was fine for 2 days. Then she developed acute hepatic necrosis. When she came into the hospital, her ALT was 7,500. We started Lipoic acid right away, and within a short time, it was normal. She regenerated her liver. If IV Lipoic acid reverses acute liver disease, it will reverse chronic liver disease like hepatitis C. We don't like to see that. In 1999, I published a paper where I took 3 cirrhotic hepatitis C patients in the process of liver transplantation at New Mexico, University of New Mexico hospitals, and administered Lipoic acid for regeneration of the livers, silymarin to protect the liver from further damage, and selenium which Dr. Will Taylor at the University of Georgia found is sort of like a birth control pill for many viruses, because viruses monitor selenium levels. The 3 patients recovered full liver function within 6 months and were taken off the liver function list. Some of the nurses at the hospital would send me the patients before a liver transplant, and almost all of them we were able to regenerate their livers, and they went out of business, by the way. There's no liver transplant program at the University of New Mexico anymore. Well, what do I think are the most important laboratory tests for evaluation of liver function or liver disease? The albumin is most important. A sick liver cannot produce albumin. The prothrombin time, the liver produces the clotting factors, and if a liver is damaged, the prothrombin time is elongated. And the platelet count, if the liver is congested or scarred, there's portal hypertension, the spleen is attached to the portal vein, and as a result of this, the spleen swells up, platelets are sequestered in the spleen, and you get a low platelet count in the blood. And the ALT goes up and down from day to day. This is a typical hepatitis C patient. He's a man in his 50s, a professional man from LA, came into the office, and he had a albumin level of about 2.6. We like to see it about 3.5 or higher. His prothrombin time was 18 seconds. Normal is about 9 to 13 seconds. So it was quite high. Within a very short time, it returned to normal with intravenous alpha-lipoic acid. When he arrived, his platelet count was about 124, as I remember. Normal is 140 to, well, I'd say about 400. And within a very short time, he had normal platelet function. When he arrived in the office, his ALT was 120. Within a very short time, it was normal. And we see this over and over again with liver disease, chronic liver disease such as hepatitis C. Well, the conclusion of my paper, I offered a conservative approach to the treatment of hepatitis C that is exceedingly less expensive. 1 year of triple antioxidant therapy, I think now probably costs about $4,000 compared to about $500,000 for a liver transplant. Are there other diseases that Lipoic might help? Lipoic acid is a potential therapy for chronic diseases associated with oxidative stress. And most diseases are associated with oxidative stress. Lipoic acid has been shown to be an effective inhibitor of HIV replication. Bauer and his gang published this, 1991. Lipoic acid protects against ischemia reperfusion injury following cerebral ischemia, and I mentioned that already. Oxidative stress in the aging rat heart is reversed by supplementation with lipoic acid. You know, when we're young, we produce tremendous amounts of this. We heal very well. As we grow older, we heal more slowly. What about Lipoic and diabetes? Henriksen published the first human study to show that lipoic acid increases insulin-stimulated glucose movement into the cell and out of the bloodstream. Lipoic acid improves insulin sensitivity, reduces oxidative stress, and improves neuropathy in diabetic patients. Singh et al., 2008. Administration of lipoic acid modulates insulin sensitivity in patients with type 2 diabetes, a placebo-controlled pilot study. 99. Tankova and others published an article, Treatment for Diabetic Neuropathy with IV lipoic acid in 2005. This study demonstrated that lipoic acid is an effective treatment for peripheral and autonomic diabetic neuropathy and also diabetic neuropathy of the cranial nerves, leading to full recovery of the patients. We see this every day at our clinic. A large portion of the people that come in have serious neuropathies. What about lipoic and cancer? Well, we all know cancer cells do not like oxygen, and you all know about Warburg. And you also know about Tom Seyfried. Wenzel and others published an article that showed this study provided evidence that lipoic acid in its reduced form can induce cancer cell death by a pro-oxidant mechanism that is initiated by an increased uptake of oxygen into the mitochondrion. Alpha-lipoic acid induces apoptosis and necrosis in liver cancer cells. She and others. 2008. Lipoic acid not only triggered apoptosis of carcinoma cells, but it also activated the mechanism of elimination of other cells with the abnormal chromosome number. Kishirina et al., 2010. Lipoic acid causes disruption of tumor metabolism, and this is followed by cell death by multiple pathways, including apoptosis and necrosis. Sakar, 2011. Lipoic acid stimulates apoptosis in human breast cancer cells, and you see also in lung cancer cells. Well, you know, cancer metabolism is quite complex. And this is from Dr. Israel in Paris. It's just a little bit of what goes on in cancer cell metabolism. But what's our non-standard cancer protocol at the Integrative Medical Centers of New Mexico? We use a lot of intravenous alpha-lipoic acid and oral lipoic acid. According to the first work, Barter and Bergson et al. At NIH. We use low-dose naltrexone after Zagan and Bahari. Hydroxycitrate after Lawrence Schwartz in Paris. A healthy diet. We use a lot of supplements like artemisinin, curcumin, etc. Prescription drugs such as metformin, cimetidine, Xanax, etc. So many of these people are so nervous and freaked out that they need a little Xanax at bedtime. But what about low-dose naltrexone? You know, I learned about this from a patient right after, you know, I got so fed up with university medicine, I became a country doctor, not far from Lubbock, Texas. My kids thought they were cowboys and cowgirls and were riding sheep and roping calves and things. And I delivered babies on ranches and just had nothing to do with university work anymore after the bad taste I had in my mouth from working at universities. And then a job opened up for the Department of Defense. I was a Department of Defense doctor for 7 years. And then I thought I'd open a little place and I would do what I think is right, and not fight with people anymore, and not drive people crazy, and they wouldn't drive me crazy. So right after I opened my office, a man walked in, and he had prostate cancer metastasized to his bones, and rheumatoid arthritis. He could hardly even move. He had a walker, and he said he had a wife with Alzheimer's. MD Anderson said he had 3 weeks to live. I don't know how they knew that. And he had to put his wife in a home before he died. Would I give him pain pills? I said, sure. Then he asked me if I ever heard of Dr. Bahari in New York. And I said, no. He said, well, he heard he was curing cancer and rheumatoid disease. So I said, why don't you go up there and see him? He says, well, he's in a little office. If he was any good, wouldn't he be at Sloan Kettering or Dana-Farber? I said, if he could cure cancer, he'd put him out of business in 2 weeks. They treat a lot of cancer. They don't cure many cancers. Then I told him about my experience at the universities in Cleveland and how they wanted to kill me because I was regrowing livers rather than transplanting livers. And he went up and saw Dr. Bahari. I thought he died. 3 years later, he walks in without his walker. And he told me that he was there because he had a cold or something. I said, what about the cancer? He said, well, Dr. Bahari stopped the growth of the cancer and cured the rheumatoid arthritis with a drug that costs $15 a month, low-dose naltrexone. And I was really skeptical about this, but I had about 70 people with rheumatoid arthritis, systemic lupus, dermatomyositis, MS, Crohn's disease, put them all on low-dose naltrexone. Within 6 months, almost all of them were off all of their Enbrel, Remicade, prednisone, Imuran, all of these things. So low-dose naltrexone, we use it every day. 1.5 to 4.5 milligrams fools the brain into thinking there are not enough endogenous opiates in the bloodstream. In the morning, there's a flood of endogenous opiates, and at least one of them is called metenkephalin. It binds the cancer cells receptors, and the cancer cells undergo apoptosis. There's several papers by Ian Zagan and associates at Penn State University on this. Incidentally, metenkephalin is a investigational prescription drug. I think it costs about $4,000 an injection. If you take low-dose naltrexone at bedtime, you produce your own metenkephalin in the morning. Well, low-dose naltrexone has many, many actions, but one of them is the downregulation of Th17. T helper 17 cell is a type of T helper cell that produces interleukin 17. Now, these cells produce tissue injury by inflammatory processes, like in Crohn's disease, MS, rheumatoid arthritis, SLE. Normally, T17 cells provide epithelial mucosal antimicrobial immunity by also producing interleukin 22, which stimulates epithelial cells to produce these inflammatory proteins that kill microbes. And this causes autoimmunity. And low-dose naltrexone seems to stop this. Well, in 2006, we published the first human study that demonstrated the therapeutic effects of lipoic acid combined with low-dose naltrexone for the treatment of cancer. The long-term survival of a patient with pancreatic cancer metastases to the liver. No interest from the oncologists. Then in 2007, I published a paper, Reversal of the Signs and Symptoms of a very serious B-cell lymphoma. He was actually on intravenous lipoic acid and low-dose naltrexone. Then in 2009, we published another paper revisiting the ALAN protocol for people with metastatic pancreatic cancer, reported 3 new cases. Within 6 months, these terminal patients showed no cancer on their PET scans. Then I received a call from Dr. Laurent Schwartz in Paris, and he called me up one day and said, you know, we've been using your protocol, and we combined hydroxycitrate to it. And we seem to be getting better results. So and he wrote an article on investigative new drugs, tumor regression with a combination of drugs interfering with tumor metabolism, efficacy of hydroxycitrate, lipoic acid, etc. So I added hydroxycitrate to my protocol. Another paper by Schwartz and colleagues, the metabolic effects of ALA, HCA allow the reprogramming of cancer cells into oxidative aerobic metabolism rather than anaerobic metabolism. This should ultimately limit the availability of compounds necessary for the growth of cancer. ALA and hydroxycitrate target at least 2 major enzymes in the metabolism of sugar: the pyruvate dehydrogenase kinase and ATP citrate lyase. Hydroxycitrate inhibits pancreatic alpha amylase, which breaks down starch and glycogen, and intestinal alpha glucosidase, which breaks down starch into glucose, leading to a reduction in carbohydrate metabolism. Studies of HCA have produced results that indicate a potential for modulation of both lipid and carbohydrate metabolism in cancer cells. ATP lyase is an enzyme that catalyzes the generation of acetyl-CoA from citrate or citrate. Acetyl-CoA is a vital building block for the endogenous biosynthesis of fatty acids and cholesterol and protein modification. Hydroxycitrate also inhibits ATP citrate lyase, which limits the conversion of citrate into acetyl-CoA, available for the synthesis of lipids and aerobic carbohydrate metabolism. This is the enzyme ATP citrate lyase. So alpha-lipoic acid inhibits pyruvate dehydrogenase kinase, and this enzyme stops the conversion of pyruvate to acetyl-CoA. More available PDH results in increased pyruvate being directed into the Krebs cycle rather than conversion of pyruvate to lactate as in cancer cells. Typical patient, amazing patient, Mrs. MC, 68-year-old woman with breast cancer. She refused surgery, chemotherapy, and radiation. She was estrogen positive, progesterone negative. She had metastases to the lymph nodes. This cancer had been going on for a long time. She went to an oncologist. He looked at her and told her, you know, you have metastatic breast cancer. You know, we could remove the lymph nodes, we could remove the cancer, it'll pop up somewhere else. He says, we give you less than a year to live. When she walked into the office, this is the way she looked. This gigantic fungoid exophytic cancer on her breast. And you see that piece of gauze stuffed into the cancer. You wonder what's going on there. But one day when she was receiving her lipoic acid, an artery busted in her breast and started squirting blood all over the place. And I wasn't there at the time, but my son was, who's in practice with me now. And he really wasn't sure what to do in this case, so he stuffed it with gauze. And it stopped the bleeding, by the way. Big, ugly tumor. That's a side view. This is an enhanced PET scan of that cancer. Gigantic cancer. And here's a metastasis, another metastasis. There were metastases to the skin, and who knows where else. This is early June. She came in March. This is after a few months of low-dose naltrexone and lipoic acid intravenously, hydroxycitrate, other things. When she came in, her CA 2729 was 60. By this time, it fell to 39. Her CA 15.3 was 27.5. It fell to 19.6. I suggested that she really see an oncologist. So there's a very good oncologist I work with in El Paso, Texas. And he's very open to different things. So she took my advice and tried her chemotherapy for less than 3 weeks. She became very ill, lost her hair, stopped conventional therapy. Now, the previous photo did not show this. Looks like after the chemotherapy, she started developing new tumors. You can't see, but they're actually popping up on her chest wall, too. So she added black salve to this regimen, which she said burned. You know, this is a bloodroot salve that she bought over the internet. And all of a sudden, the whole cancer formed this big scar. This is in August. Bloodroot salve. I was amazed. Then a few days later, the cancer fell off on the floor. Can you believe that? It's amazing. And this is what resulted. There's a big ulcer, which is healed now. And you can see all of these metastases on the chest have all dried up. This looked terrible, but all through this, she was feeling great, never complained. August 14th. Her CA 2729 dropped from 60 to 11.5. Her CA 15.3 dropped from 27.5 to 7.3. This was in March of this year. Rather than having all kinds of tumors, she just has a big scar, a big scab over this area. And today it looks much better. I wasn't able to get a picture. You know, sometimes people are sensitive about taking pictures, but I think I'll get one soon. My first interesting cancer patient, a long-term survival of a patient with pancreatic cancer, metastases in liver. A young man, his local oncologist said, you know, don't do anything, just go to hospice. He had a young child, a pretty young wife, 44 years old, never smoked, never drank, you know, just took very good care of himself, very good physical condition. So his wife dragged him into the office, and this was the first published study demonstrating therapeutic use of lipoic acid combined with LDN for cancer. I asked him if he wanted to try our therapy. He said, yeah, you know, he was very depressed at the time. And when he came in October of 2002, he had this big pancreatic tumor with many metastases to the liver. He went to MD Anderson to get another opinion. So we could give you chemotherapy, but we don't think you'll live through the year, probably 3-4 months. So he did our treatment, and this is February 2006. The tumor's still there, but he went back to work in 2 months, by the way, with just felt great, felt normal. And some of the metastases are there, but he showed no indications of having cancer. This is 4 years later from his terminal diagnosis. And then in 2008, the tumor seems to have not really there anymore, and the metastases have disappeared. The liver tumors, the metastases have sort of scarred over. In 2009, we did another PET scan. It showed no cancer. And his family said, you know, you've been going to this place from 2002 to 2009, twice a week, spending a lot of money on these IVs. You're cured. Stop going. You know, we don't have that kind of money. He's an engineer. He probably could have afforded it. And he stopped. Within a year, the cancer came back. And rather than coming back to us, his family said, you know, insurance doesn't cover lipoic acid. Why don't you go back to MD Anderson? How much time do I have? Okay. It doesn't cover lipoic acid. So he went to MD Anderson, they gave him chemotherapy, and he died right afterwards. But he lived for 10 years after a terminal diagnosis. Then right afterwards, we published another paper revisiting this protocol, a report of 3 more cases, 3 more stage 4 pancreatic cancers. This is a woman from San Francisco with many metastases in the liver. January 2006, within 6 months, there was no sign of cancer on the PET scans. Her doctor promised me she would continue therapy. When this woman returned to San Francisco, the doctor said that, you know, I'm sorry, I'm not going to do it. I'm afraid that the other doctors will think poorly of me. And about a year later, the cancer came back. Hepatocellular carcinoma following hepatitis C. 60-year-old RN. She had a finger stick. She developed hepatitis C. She drank. She smoked. Within a short time, she developed numerous tumors of her liver. She went to the big medical center. They said nothing could be done with this. She will be dead within a few weeks. This was October 2006. Came to see us in January 2009. All cancer is dormant, no sign of cancer in the PET scan. Reversal of a B-cell lymphoma, a man with big tumors in the neck, and in the left groin, they were the size of softballs. He did our treatment. He had only 2 weeks of lipoic acid intravenously, but kept doing the LDN. Within 6 months, no sign of cancer. This is a very interesting patient. Mr. JT, 68-year-old male, diagnosed in 2008, urinating blood. CAT scan showed left kidney cancer, Mets 2 lung, had a left nephrectomy. MD Anderson administered biological response modifiers and chemotherapy. Nothing worked. He was told to get his affairs in order. He'd be dead within a very short time. He came to see us. When he came in, he had this left nephrectomy and this big tumor in his lung. This is a enhanced PET scan showing this gigantic tumor. By 2014, no sign of cancer. He's still working every day and feeling completely normal. Well, you know, the average oncologist had absolutely no interest in any of this stuff. But one day in 2007, I received a call from the National Cancer Institute. Dr. Abrams called me up and said, I've been reading your work. can we fly to Washington and teach us what you're doing? I thought they'd argue with me. I went there and gave my speech. They actually stood up and applauded. And afterwards, one of the, I won't tell you who he was, but this Indian fellow walks up to me and says, I'm head of oncology at this big cancer center. I said, what could I do for you? He said, I flew down just to hear you speak, Dr. Berkson. He says, I have an aunt with breast cancer. How should I treat her? I said, what do you do for your patients at your institution? He said, well, they get chemotherapy and radiation just as they do everywhere else, but not for my aunt. Can you believe this? So one of the chiefs over there at the National Cancer Institute said, this is interesting stuff, but don't get your hopes up. It'll never catch on in America unless we have a Great Depression. Well, in 2012, they invited me back. So maybe that's what they're expecting. And they told me that I could speak for a whole afternoon. And after each patient that I presented, they had their pathologists and radiologists critique the case. And they pretty much agreed with everything. And they're doing some studies in Washington now at NCI with, they actually hired a doctor to do these studies. I don't know how they're coming along. And when they find out it works, they'll say they discovered it at NCI, won't they? So anyway, that's NCI. They concluded that the cases presented today by Dr. Berkson were submitted and given rigorous scientific evaluation. The ultimate goal to identify these integrative medical interventions. Dr. Berkson reported that a combination of ALA and LDN, along with diet, vitamins, etc. Early in his medical career, he published papers using ALA to repair liver damage, mushroom poisoning, and chronic liver disease. He also cited a number of research articles. Seems like, I see Dr. Yanagisawa here. Seems like everywhere else in the world they seem to be interested in this. But in America, you know, I don't know. What about ALA and for systemic lupus and rheumatoid arthritis? I think it works best for these things. We're in process of getting this ready for publication. Almost everybody gets better with this. It's amazing, but it's cheap. Summary. Lipoic acid is necessary for aerobic cell life because ALA is essential for the conversion of pyruvate to acetyl-CoA. ALA is the rate-limiting factor for the production of energy. ALA prevents pyruvate dehydrogenase kinase. ALA forces cells from an anaerobic metabolism into an aerobic metabolism. ALA has many uses in human medicine. The efficacy, the apparent lack of toxicity, long clinical record, all point towards the need for a clinical trial. Well, why aren't there any large-scale clinical trials? Drug company, vice president, confidential statement. I got a call from the Mayo Clinic many years ago when I was the FDA principal investigator. One of their doctors asked me, one of their chiefs said, do you think it'll work for diabetic neuropathies? I said, yes. And I sent him many cases, I think up to 50 cases. Never heard from them again, by the way. But in 2004, they published this paper that they took 1,200 people coming in for possible amputation of the toes. And within 3 weeks of IV lipoic acid, they grew new blood vessels, new nerves in the toes, and had normal toe function. The drug company vice president said to me after I said, why aren't they doing it anymore? He said, we went one drug for one indication. Lipoic acid has too many indications, and this drug is bad for business. Companies are working hard to change the alpha lipoic acid molecule so it can be used as a patented drug. However, up to now, the corrupted molecules don't work nearly as well as the natural molecule. All of these cancer patients, I tell them they need an oncologist, and we have some that works along with us. Most of the patients I see have hepatitis C, diabetics, SLE, RA. Patients sign and form consent forms, conventional therapies explained carefully with complete objectivity. Most cancer patients that I see are considered end stage, and they are told by their oncologist that nothing can be done. And I have to add this lecture is just my experience. Books describe my therapies. Also, if you type in Berkson BM on Google Scholar or PubMed, you see a lot of stuff in cell biology, microbiology, and in medicine. Well, thank you, folks. This is a pleasure.